hyperkalemia in MRA therapy and how to manage hyperkalemia in a patient with combined drug therapy with the MRA, RAS inhibitors, SGL2 inhibitors, often associated with the heart failure drugs like ACE or ARB. So this will be the outline of my talk. So I'll bore you with some bit of basic physiology and pharmacology, and I will emphasize the role of mineralocorticoid receptor antagonists in medicine and the treatment of hyperkalemia associated with MRA therapy. Coming to the potassium handling by the kidney. So the kidney is a major organ where potassium is excreted by the body. And of course, in patients with chronic kidney disease, some amount of excretion happens in the colon. And potassium is filtered at the glomerulus, and around 90% is reabsorbed in the proximal convoluted tubule and the thick ascending limb of Lupus-Henle, and about 10% is presented onto the distal segments, like that is a distal convoluted tubule, connecting tubule, the cortical collecting duct, the medullary collecting duct for secretion. So the main part of the kidney that deals with the secretion of potassium ion will be the distal convoluted tubule, connecting tubules, as well as cortical collecting tubule, as well as a medullary collecting tubule. And in the distal convoluted tubule, it is divided into two segments. That is a D1 segment and the D2 segment. D1 segment is the initial part of the distal convoluted tubule, where you have a cell which has the sodium chloride co-transporter, and this is a co-transporter on which the thiazide diuretics act. And here what happens is that the activity of this co-transporter is driven by the sodium potassium ATPase. So the sodium potassium ATPase, as you recall from your physiology days, is an electrogenic pump. So it creates an electrical distribution across the cell, so that it pumps out 3 sodium out of the cell and it pumps in 2 potassium into the cell. And because of this, because of the potassium being actively pumped out into the blood, there will be electronegativity inside the cell, and it acts as a stimulus for the sodium to move into the cell. And for along with the movement of the sodium, the chloride also moves in. And the one more pump is there, which is actually not shown in this diagram. There is a potassium transporter which transports potassium out of the cell along with the chloride. And for the optimal activity of the pump, you need a distal convoluted tubule delivery of sodium to happen. So unless and until there is a distal delivery of the sodium, which happens to the distal convoluted tubule, the activity of the cell is less. So there will be excretion of the potassium out of the cell also will be low. So a proper amount of the urine rich in sodium should reach the distal convoluted tubule for potassium excretion to happen. And along with the distal convoluted tubule, in the distal part of the distal convoluted tubule, there is a principal cell. And the principal cell is an active cell where it's a primary cell which deals with the potassium excretion from the body. So what happens is that when there is a state of hypovolemia, there will be decreased filtration at the glomerulus. There will be decreased delivery of the sodium, which happens to the distal convoluted tubule. So the activity of this sodium chloride co-transporter is decreased. So as a result, more sodium will be delivered onto the principal cell. And it is a principal cell which actively secretes potassium ion. And it is the cell where aldosterone plays a major role. So in the principal cell, there is a pump which is known as a sodium potassium INAC channel. So the INAC channel is under the control of aldosterone. And again, the activity of the pump is driven by the basolateral sodium potassium ATPase. So there will be movement of the sodium into the cell, and the potassium is excreted out by means of the ROMK channels, renal outer medullary potassium channels, and the MAXK channels. So this is what happens in the principal cell. And the aldosterone exerts its major action in the principal cell. And because the sodium is actively reabsorbed into the principal cell and the potassium is excreted out, when the fluid moves down, there will be a negativity of the luminal charges which happen, and there is a close interaction with the type A intercalated cell, which is involved in the reabsorption of the potassium, actually, whereas type B cell is involved with the secretion of potassium. So this is the principal cell. So the principal cell, whenever there is increase in the aldosterone, there will be increased activity of the INAC channels, and there will be increased activity of the sodium potassium ATPase. And all these are in the principal cells. Now, the renal potassium excretion is decreased in the following settings. That is, absence or very low levels of aldosterone typically happening in hyperonemic hypoaldosteronism. WNK and WNK4 mutations, these are thought to modulate the activity of the sodium chloride co-transporter. Low sodium delivery to the distal tubule, which I explained earlier, low urine flow, low serum potassium levels, and kidney disease. Now, what does aldosterone do? Aldosterone is a mineralocorticoid, so it is a steroid hormone. And the aldosterone, which is transported from the blood, which is secreted by the adrenal cortex, reaches a principal cell, and it binds to mineralocorticoid receptor ligands, where it increases the activity of the serum as well as glucocorticoid inducible kinase, KRAS-A, and the corticoid steroid induced factor. And all these things will increase the activity of ENaC, and it will increase the activity of sodium potassium ATPase in the basolateral membrane. As a result of the increased activity of the sodium potassium ATPase and the ENaC, there will be increased reabsorption of the sodium and excretion of the potassium. So this is the primary way in which aldosterone acts. Initially, when the aldosterone level goes up, it increases activity of the ENaC channels as well as it increases activity of the sodium potassium ATPase. But however, as aldosterone activity continues to rise, there will be increased synthesis of this ENaC channels as well as there will be increased synthesis of the sodium potassium ATPase. So this is a primary stimulus for aldosterone production. All these are basic physiology. Whenever there is a drop in blood pressure or drop in the fluid volume, there will be renin release from the kidney. Renin converts angiotensinogen produced by the liver into angiotensin 1. And into the lung, the angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. Angiotensin 2 acts on the adrenal gland to stimulate the release of aldosterone, and aldosterone acts by reabsorbing sodium chloride and water. So this is actually the basic physiology, but however, you should remember that there are much more effects of aldosterone rather than the primary reabsorption of the sodium, water, and kick out potassium. So the adverse effects which have been noticed in various experimental studies include renal fibrosis. It produces tubular interstitial fibrosis. It triggers inflammation, so that it triggers tubular interstitial inflammation and it causes tubular atrophy and interstitial fibrosis. It can damage the podocyte, causing podocytopathy, leading to proteinuria and worsening renal function. It causes albuminuria and proteinuria, which is a hallmark of progressive kidney damage. Then it causes hypertension and fluid retention, promotes sodium reabsorption and water retention, which raises the blood pressure and it increases the workload on the kidney. So ultimately, what it leads is that it leads to chronic kidney disease progression. So it is this part which we are more interested in. So what is the aldosterone has got a genomic pathway action and a non-genomic pathway action. So the aldosterone, when it is being a steroid hormone, it goes into the cell and binds to the steroid ligands, which is found in the cytoplasm. And the aldosterone steroid ligand can exert two functions. One is a genomic pathway, that it is crosses into the nucleus and it increases the gene transcription of the sodium potassium ATPase as well as it increases activity of the ENaC channels. Whereas in the heart, it causes hypertrophy. And the non-genomic action is mainly by cross-talking with other receptors, like it cross-talks with the angiotensin 1 receptor, it cross-talks with the epidermal growth factor receptor, and it cross-talks with the other receptors. So what will happen is that the estrogen receptor also is stimulated. So ultimately, it leads to the non-genomic pathway, which includes oxidative stress. It causes fibrosis, it causes inflammation, it causes apoptosis. So these are the non-genomic pathways and ultimately leads to into organ failure and organ fibrosis. So these effects were well documented. So this is a contemporary review from the Journal of the American Heart Association. So it has gotten multiple adverse consequences for cardiovascular, cerebrovascular, renal, and metabolic disease, independent of the blood pressure alone. So it acts beyond the sodium and water, and it causes a myriad of organ complications. So just to highlight what it does to the heart. So aldosterone, whenever there is an aldosterone excess, it causes endothelial activation. It causes monocyte extravasation into the vascular cells, vascular endothelium, as well as the lining cells. and it transforms the monocytes and it activates the monocytes, and it can cause atherosclerosis leading to myocardial infarction. Again, it can cause collagen deposition, can lead to myocardial fibrosis. It can lead to systolic heart failure. Then it causes the cardiac hypertrophy of the myocardium. It causes myocardial hypertrophy, and it can cause a diastolic heart failure. And diastolic heart failure and systolic heart failure ultimately will lead to atrial remodeling, and it can lead to atrial fibrillation. So all these are the end effects of the last effects of aldosterone. So it causes myocardial infarction, heart failure, diastolic as well as systolic heart failure, and it also causes atrial fibrillation. So the effects can be myriad, like endothelial dysfunction, decreased vascular compliance, can lead to stroke, renal failure, coronary artery disease, and myocardial infarction. So the effects can be high blood pressure, stroke, leading to increased vascular atherosclerosis and increased inflammation, heart failure due to the various things which I had mentioned earlier. Then it's also implicated in the pathogenesis of diabetes and metabolic syndrome. It is involved in atherosclerosis, and it can lead to active progression of kidney disease, leading to kidney failure. So the mineralocorticoid receptor overactivation will lead to homeostasis problems, metabolism, then inflammation, vascular access, ultimately leading to something like a cardiorenal syndrome. It causes a glomerular injury, fibrosis, and kidney failure. It causes fibrosis of the myocardium, cardiac remodeling, and heart failure. So it is important that the mineralocorticoid receptor antagonist offers nephroprotection, cardioprotection, as well as vasoprotection. So these effects have been recognized earlier on by various researchers. And so this is actually the basis why mineralocorticoid receptors are so important in clinical medicine. So I'll go to what are the currently available mineralocorticoid receptor antagonists. So mineralocorticoid receptor antagonists in a broad term are classified into steroidal mineralocorticoid receptor antagonists and non-steroidal mineralocorticoid receptor antagonists. The classical one is a new drug that we use, which is known as Finrenone. So this is a mineralocorticoid receptor selectivity, which is highly selective for Finrenone. The potency, again, the spironolactone is very potent. Finrenone is also thought to be potent, a very potent mineralocorticoid receptor antagonist. Then the tissue distribution, the spironolactone and the eplerenone mostly have more distribution within the kidney, whereas Finrenone, the distribution between the kidney and the heart is almost equal. And the half-life is maximum for spironolactone, whereas it is very short for Finrenone. And the animal models studies have all shown that Finrenone, they compared Finrenone versus eplerenone. When Finrenone was compared with eplerenone, there will be decreased macrophage invasion, decreased cardiac fibrosis, and increase in the longitudinal strain of the myocardium. Then it also causes decreased renal fibrosis, renal dysfunction, decreased endothelial dysfunction, decreased oxidative stress. All these are important. Then it decreases a cardiac remodeling, decreases a proteinuria, and decreases a marker of heart failure. So spironolactone, mainly it is used in arterial hypertension, primary hyperaldosteronism. It can be used in liver cirrhosis and heart failure with reduced ejection fraction. And the side effects are mainly the disruption of the menstrual cycle, gynecomastia, breast pain, impotence, and the loss of libido and hyponatremia. Eplerenone, it is steroidal. It is slightly more specific than mineralocorticoid receptor than spironolactone. Again, it is used in arterial hypertension, heart failure with reduced ejection fraction. Then the side effects include hyperkalemia, increase in the serum creatinine, diarrhea, cough, fatigue, dyslipidemia, etc. And Finrenone, we'll discuss Finrenone in a bit more detail. It is a non-steroidal, more mineralocorticoid specific, and it is useful for the prevention of a glomerular filtration rate decline, the occurrence of end-stage kidney disease, cardiovascular causes of death, and non-fatal myocardial infarction, and the prevention of hospitalization of heart failure in patients with diabetic kidney disease. Then it is generally prescribed with a eGFR, which is more than 25 ml per minute per 1.73 meter square. And you should have a potassium which should be less than 5. Now, the key randomized clinical trials. Now, coming to the clinical scenario, the most important data is by the Fidelio DKD trial and the Figaro DKD trial. So here the Finternon was compared with the placebo in type 2 diabetes and chronic kidney disease, where it showed there is a decrease in the kidney failure, decrease in the eGFR reduction, and renal endpoints and death. Figaro mainly dealt with cardiac patients and cardiovascular outcomes. Again, the study population was type 2 diabetes with chronic kidney disease. They showed a decrease in the cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, or heart failure hospitalization. And now there is a recent NEJM article which has been published in the recently, which has shown the use of Finternon in type 1 diabetes and chronic kidney disease. Earlier, it was restricted to type 2 diabetes. Now there are data which shows that it is equally effective in type 1 diabetes, which is published in March 4, 2026. Now, what about the society guidelines? So we always look at the society guidelines to boost up our prescriptions and to ensure that there's a validity in our prescriptions. So this is a KDIGO 2026 clinical practice guidelines, and it is a draft publication, and it is for a public review. And it has stated that in the section with mineralocorticoid receptor antagonists, the recommendation is that they strongly recommend adding a mineralocorticoid, non-steroidal mineralocorticoid receptor antagonist with a proven kidney or cardiovascular benefit for people with type 2 diabetes, eGFR more than 25, and a normal serum potassium concentration and albuminuria. Albuminuria is UACR more than 30, while on maximum tolerated doses of RAS inhibitors. The last one is also important. So still, RAS inhibitor is still the primary one which we have to use, and the level of recommendation is 1/8. So it is a very good level of recommendation for non-steroidal mineralocorticoid receptor antagonists, especially in diabetic kidney disease. So when you are looking at a goal-directed medical therapy versus a conventional therapy, when the goal-directed medical therapy is based on the published data and the data and literature. In diabetic patients, you use the pillars of therapy are sodium glucose, the SGLT2 receptor inhibitors, GLP-1 receptor agonists, non-steroidal mineralocorticoid receptors, and RAS blockade. When you compare it with the conventional therapy, like when you are using only RAS, so this is a survival of these patients, the Kaplan-Meier survival curve. It shows that the combination therapy is always superior, and it adds a difference of close to around 5.5 years to these patients with type 2 diabetes mellitus and chronic kidney disease. So it is imperative that you should use a mineralocorticoid receptor antagonist along with the combination therapy. Now, despite the guideline recommendation, what is the number of people who are actually on ACE inhibitors or mineralocorticoid receptor antagonists? So ACE, it is only 36%. ARB, maybe the data is even less. Maybe it is around 3%. This is based on Western data. Mineralocorticoid receptor antagonist is around only 36%. Heart failure in patients, again with heart failure, ACE is only 15%, ARB is only 10%. Mineralocorticoid receptor antagonists, of course, the cardiologists are good in writing spironolactone and other mineralocorticoid receptor antagonists. Again, the percentage of people is 60%. Those who are on ARNI is only 30%. So despite all these recommendations, the proportion of the patients who are on combination drugs as well as the optimal use of the drugs are actually very minimal. Now, what will happen if you stop RAS inhibitors? This is with regards to RAS inhibitors. So when you stop RAS inhibitors, it is found that the mortality rate steeply climbs. When you discontinue, when you down titrate, the risk of mortality increases drastically. Whereas those people who are on still on RAS inhibitors, they had the mortality rate is much less. So with the RAS discontinuation, the mortality increases by around 55%. And again, with the RAS down titration, again, the mortality rate almost approximately touches those with the RAS discontinuation. So it is important that these people should receive the RAS inhibitors at a full dose, and they should be on a combination therapy. So how do you treat these patients? There are non-pharmacological treatment as well as pharmacological treatment. And pharmacological treatment include diuretics, sodium bicarbonate, and calcium exchange resins. Now, the KDIGO guidelines ensure that the newer potassium binders should facilitate should be used, and the potassium binders should be considered before reducing RAS, and the RAS discontinuation should be the last resort. So the Newell potassium binder is Lokelma. I think we had an extensive discussion of Lokelma in the 2 previous sessions. So the Lokelma, I'll just brush through the slides. Lokelma is highly selective, rapid onset. There is good evidence in hemodialysis, and there are guideline recommendations. The correction phase, you use twice, 3 times daily for about 1 to 2 days till normocalemia is achieved. And in the maintenance phase, you use one sachet per day. Then it can also be used in patients on hemodialysis, on non-dialysis days if the potassium is high. Then this is how you administer the Lokelma in 45 ml of water. And it can be given along with other medications or without food. So this is sodium zirconium cyclosilicate will continue to deliver data on hyperkalemia management, and it is a very good drug in preventing hyperkalemia. So I'll just go through the heart failure also. So it is also important in heart failure management, hyperkalemia. Thank you.